imerudi haraka.
Iko sawa. Haya, sawa. So ni check nione iko live sasa hivi. Si ndio? Acha tuipige. Okay, live. Tunaweza hivi nimesahau
Tunaweza edit.
utaimute ama hiyo iko sawa, tuongea ongeza tu utamute wapi? Ni microphone kama utamute wapi? Niko na dakika kama 5. In 3, 2, 1. The microphones utanconfirmia kama umeunmute. So give us a cue. 1, 2, go. Karibu sana daktari.
Thank you so much for having me.
So for the viewers, I guess maybe there could be other people are listening. My name is Duncan Motanya. We are recording live from DMMC Studios at Ngara. DMMC is a Diabetes Management Medical Center, and we, having a chat with Daktari that we need to do something a bit random but nice, especially to people in our communities. So asante sana, Doc, for agreeing to come at this time, to have this chat. So maybe I could give you a minute to introduce yourself, maybe because there are a couple of people could be watching and they don't know, who's Dr. Prisca.
Thank you so much, Duncan. I'm Dr. Prisca Mungla. I'm a physician, diabetes specialist, and endocrinologist, and we partner well with DMMRC. Usually, I run the clinic on alternate Saturdays, so I'm sure some of the members of the community we've interacted a lot, and we are yet to interact with many more. And I think as much as it's late on a Friday, the opportunity couldn't have been better because this is World Diabetes Awareness Month. So I think this session will really be insightful to everyone.
Yeah.
Yeah.
That is very true. So maybe for also a couple of people who could be watching, every November, we celebrate the World Diabetes Month. I think this is a day that was set up by WHO, I think around in 1992. So we just celebrate, and come together and look at the milestones that we have achieved, I think, as humanity. But that is not, what we are here to do, to discuss today. So, um, I mean, also maybe to briefly introduce myself, just in case there's anyone who is watching and doesn't know me. So Duncan Mutanya, as I said, is my name. I am one of the directors at Diabetes Management Medical Center. So DMMC runs a clinic or more or less like a diabetes specialist clinics every Saturday with Dr. Prisca. But at the same time, we also have a pharmacy. Uh, we also have a laboratory. Generally, we are a medical center. So we are based here in Ngara. And one of the, I think, unique services we offer is that you're able to order your medication online, and we are also able to deliver anywhere you are in the country. So, Doc, the post I shared to the people, to I think some of the people in our WhatsApp group, has a lot of information, and I just don't want us to talk about it right now. A lot of information it has a lot of it has to touch with complications, that are diabetes related. But maybe you could walk us a little bit back. I mean, before a person is diagnosed, what really happens, up to the point where now a doctor will tell you, look, now you have type 2 diabetes, or you have to be on medication and all that. Because next to the question I wanted to ask you is, after diagnosis, well, what determines what kind of medication you give to someone? So you can walk us through what happens before you get diagnosed and how the diagnosis is done, and also, what determines what medication someone is put on.
So I know the audience might be mixed. So you might have some people who have diabetes, some people who don't, who are also just curious. So for a start is maybe we define what diabetes is. So diabetes, simply put, is just elevated blood sugar. And usually it depends on what time you test your blood sugar. So if you test in the morning, you've not eaten anything, that's what we call a fasting blood sugar. So if you have a fasting blood sugar of more than 7, then we would likely say you have diabetes. Then if you've eaten, and usually you measure 2 hours after, if it's more than 11.1, then it would most probably indicate that you have diabetes. Or now if you do randomly, what we call a random blood test, and it's also more than 11, then it would probably indicate that you have diabetes. But as you had rightfully put it, people don't wake up overnight and you find that you have diabetes, especially with type 2 diabetes. Type 1 might be different, and people might wonder what is type 1 diabetes, what is type 2 diabetes. So, in general terms, and for simplification of our educative session for today, we can broadly classify the diabetes as either type 1, type 2, or diabetes in pregnancy. So, if you have type 1 diabetes, which mainly we see in young children, then you find that it's because the body does not produce enough insulin. In fact, they don't have any insulin at all. And you might wonder, what is insulin? So insulin is an important hormone secreted by the pancreas, and it will regulate your blood sugar, especially after a meal. So type 1 do not have insulin at all.
What happens? I mean, how come you're saying they don't have?
So what happens is you have a combination of genetic risk factors, and then usually it's a situation where I want us to look at it like if you have an infection, you'd produce what we call antibodies. So antibodies are what would fight for you. They're like your soldiers within the body. So what happens in these patients who have type 1 diabetes is they get an infection, then their genes are a bit different. So you form antibodies towards the infection, but then it starts seeing like the pancreas could also look like the infection they're fighting. Then it fights the pancreas. Then now the pancreas undergoes a series of inflammation and ultimately death. So now it doesn't produce for you enough insulin. And even that one happens gradually, slowly over time. It's just that it's usually difficult to pick it up early. So that's how come our young children usually would just present all of a sudden when they are very sick in what we call DKA, which is the most common complication for type 1, because that's the time that the body doesn't have enough insulin.
We'll come back to that. Yes, so type 2.
So type 2 is interesting because type 2, other than just your genetics and also your risk factors for age, lifestyle really plays a big role. So you find that now when we eat wrong, remember it's Friday, we might live here and brunch.
Sherehe.
Twende sherehe kidogo.
Yeah.
But those are some of our risk factors. Poor life, eating choices,
So poor eating
sedentary.
choices means like you're eating what kind of food would qualify as poor?
So, poor just means that eating a lot of junk food, processed foods, you've moved away from the typical healthy, what people call organic, but it's more of this fast processed unhealthy food. But other than just that, you're also not exercising enough. So we become overweight. Then that fat, when someone calls you mzito, where you think it's that one pack, it's a sign of status. Not really. It's mainly you've accumulated what we call abdominal fat, and that makes it difficult for your body to process insulin very well. So that's why you'll find they sort of usually have a bit of insulin resistance. So in type 2, you have the pancreas might be producing enough, but the uptake is poor. That's insulin resistance. Or you just have a relative deficiency as also the body ages with time. So that's why for type 2, it's easier when you do like lifestyle measures, they tend to do better.
What degree does genetic predisposition like play on type 2? Is there?
You can say even like around 30%. Yes. Yeah. And also you really need a strong family history. So if you find you're in a situation that your mom has diabetes, your father has diabetes, then even if you look at your lineage on your maternal, paternal side, very many people have diabetes, your risk is higher. Vis-a-vis if you come from a family where just maybe one or two on one side you don't have. So the genes also play a part, but remember, some of these lifestyle issues now push you up higher. That's how come you can find in a family, maybe let's say you're five, then only just one person gets, the rest don't get. Yeah.
So, all right, I think that's quite clear that how you live your lifestyle, sedentary lifestyle. You have mentioned, diet. Of course, that also small aspect of genetic. And now, of course, and you put it nicely to us that the diagnosis would depend whether it's fasting blood sugar, whether it's random blood sugar, or whether it's maybe the other one. I
The
think it's
2 hour post meal.
yes, yes.
Yes.
So then, before that diagnosis, are there signs and symptoms that a person start seeing early, maybe even months before diagnosis?
Yes.
Yeah.
So remember, also a majority are asymptomatic. And by asymptomatic, we mean that you do not exhibit any symptom at all. And that's why sessions like this, your forum, are usually very important to keep reminding people that it doesn't hurt to get your blood sugar checked anytime. Just walk into any pharmacy, walk into a clinic, and just get it checked. Or even if your parents have the glucometer, just be curious and check. Majority do not have any symptoms. But in case now the symptoms start showing, is usually because of that elevated blood sugar. So things like excessive thirst. And to say you have excessive thirst, you also need to know what is your normal drinking water habits. If I'm those people you find, these days it's also fashionable walking around with those big,
Yes.
those big bottles. So
Sometimes I doubt if it's just only water. Okay. Something else. But yes, yes, go
I
on.
see people who have added things, but
Yes.
mainly, so you need to first define what is your normal. So if I'm used to taking like that 2 liters in a day, then all of a sudden I find I'm taking like extra. That's when you start noticing there's a red flag. So excessive drinking of water. And with excessive water intake, then of course you'll have to pass urine a lot. So you find your bathroom breaks are really many, and even at night. Then even for your children, at times you'll notice you've already potty trained them, so they're able to wake up, but then all of a sudden you find they're having accidents, they are wetting the bed. So that should already tell you that there's something wrong. Then of course, unintentional weight loss. So this means you're not on any extreme diet, you're not doing any exercise, but your weight is just going away. Then also excessive eating. So you're always just hungry all the time. So you're eating, but you're also losing weight, which is contrary. If you eat a lot, you'd expect that you gain a lot of weight. Then just fatigue. So if you just find you're so tired out of the ordinary, and even with children, you can notice that, so that they're not going outside to play. They always just look like they want to sleep. Some people even have labeled people as being lazy, but it's just that the body is so tired because you don't have that energy to move on. Then at times for ladies, you find recurrent UTIs, urinary tract infections, or recurrent yeast infections, or even you just have wounds that don't heal. And the wounds can be anywhere on your legs, even on your hands, but most of the time we see them on the legs. Then even men, at times their first presentation is they come whispering into your ears. The machine is not working anymore.
Oh,
Yes, bedroom matters, things are now a little bit on the trickier side. Yes, and that can be your very first.
it's kind of
Uh,
sign.
yes, that can be your just the first sign is you're like, I used to do so many rounds, and now it can even barely.
Okay.
Your wife even will start
I mean,
accusing
you're
you of doing
sleeping
other
out there,
things.
man.
Oh
Sleeping.
yes, oh yes. Then you just find it's the sugar, or even at times in children, because them they tend to present with extreme presentations, because them their symptoms are a bit abrupt.
For type 1.
Yes, for type 1, that's why you find they have what we call nausea, vomiting, they have tummy pains. Some even are usually just comatose, like they are unconscious, but they do better than the adults. But the type 2, remember, it's slow. In fact, by the time we diagnose you, you're having these symptoms, you've had a stage we call pre-diabetes, and it can last anywhere from even 5 to 7 years, where your body is just slowly, trying to acclimatize itself until it reaches the
Exactly.
point of no return.
All right, Doc. So then we've looked at these two conditions, type 1 and type 2, and how they present themselves. But now my other question would be, now what determines the treatment? Maybe for example, different people on type 1 can get or type 2. And I'm saying this because in our groups, I see a couple of people, who are on different medication, different strengths. So what determines really, especially at the point of diagnosis? And also maybe later on you can touch on different types of insulins, for type 2. What are the options for treatment, sorry, for type 1? But also generally paint a picture of what determines the treatment for type 2, and including the type of medication and also maybe the strength.
Yeah. So remember, once we make the diagnosis, usually we really try to classify you in the categories as much as we can. But remember that the classification is changing. Yeah, so you might find the latest WHO, there are just so many overlaps. But type 1, type 2, and pregnancy is just for simplification of terms. And that's why you find at times different patients have different options. But so if we look at type 1 first, so we've agreed that in type 1, they do not have insulin at all. And remember, it happens in our young children. We also see it in the teenagers. Those are our common age groups. But also, there are those adults, and we call it late onset autoimmune diabetes in the adult. So there are also adults that you can classify as a type 1. usually within the age of around 30, 45. How you at times you suspect they are different from the ones who are typically you see in type
Type
2.
2.
So they
Mm.
are not overweight,
Mm.
they tend to be very lean. Then at times, because of age, you might think, this is type 2. You try them on the oral tablets, you realize their sugars are not getting well controlled, and you switch.
Yeah.
So type 1 treatment is only insulin. No two ways about it. There's nothing else. No orals, no nothing.
Nothing.
So insulin, and then of course diet and lifestyle changes. Then we'll see the various types of insulin that they have for options. Type 2 now again is different. That's why I usually tell all my patients, I know you can be in the same group, but you're all on totally different medications. So what determines who gets what is now once we've diagnosed you with the diabetes, especially in type 2, the other uh, thing we do is screen you for the complications. That's why I write for them a whole list of labs to do.
Tests to do.
Yes.
Okay.
Times they complain, but it's for their own good. I know pockets,
Finances, true. Yeah.
finances, things are a bit tough, but you have to screen. Because remember, as we've said, they would have the diabetes or abnormal sugars for a long period of time. So some of the complications set in. So that's why we emphasize on eye check. We'll send them for heart evaluation. We'll check their kidneys. Some when they come with the issues of the nerves, the vidondas on their feet, you already know they are getting what we call neuropathy or erectile dysfunction. That's already like neuropathy. Some attempts that at diagnosis they have complications, strokes, and all that. So once you check their risk, then you classify them. Then, of course, there's a test that most of our patients are conversant with, the HbA1c.
See, yes.
Yes, in simple terms, it just gives me the average of what your sugars have been in the last 3 months.
Okay.
So, depending also on what that HbA1c shows us. So, if the HbA1c is above 7, already it confirms the diagnosis of diabetes. So, we'll do it at baseline, at diagnosis, and then for follow up.
Okay.
So the people who at diagnosis, you find that it is more than 10, it tells you that average their sugars are usually above between 10 and 15. So if you want to lower them aggressively, those are the ones now you'd consider insulin
Okay.
upfront. If at times I find you're in between, 7 and 10, you seem motivated, would give you combination of oral tablets. But remember, even these oral tablets are many. Yes. So we'll choose what is best for you. And also, if you already have some of the complications, there are certain oral tablets that are superior than others. Then also, if some of our agenda is to do things like lose weight,
Okay.
there are certain medications that tend to be more powerful in losing weight than others. So that's why you decide. Some people you start insulin, some people you start tablets, some people you combine. So you really stratify, and it's not one blanket that fits all, but usually we sort of say you individualize,
Okay.
yes, your
So,
treatment.
so let me ask you, Tari, then. And this is off the literature, sometimes I come across and read.
Mm-hmm.
Um, why, why is the first, let me say, action, or rather, decision generally for the doctor, let me say, why would it be medication? Why not something else first? So, and of course, I'm asking this to just slightly maybe ask you to explain a little bit better. Does it mean that, for example, if you decide to go on insulin, as you mentioned, a bit aggressively, is it why is the reason? Is it to help, maybe the person, maybe avoid complications? What is the reason? But also, secondly, most importantly, why not any other intervention first, apart from medication?
Okay, so I know the interventions you're thinking about are diets
Yes.
and probably exercise. So what I want us to visualize is, if you remember the moment I was telling you, by the time we are diagnosing you with diabetes, you've had it for some time. So usually if you go for your like wellness checks, just routine checks when you're not unwell, then I might be able to capture you in the stage we call pre-diabetes. If I capture you and you're pre-diabetic, that's the place that we have the luxury to say that, you know what, we are not yet there yet. Yes, it's like the traffic lights. You know, red, danger,
Yeah.
you already
Yeah.
have diabetes. Green, we are good, sugars are normal. But Hapa orange, yes, it just tells you like get set.
Yeah.
Yes. So here, if you work hard in terms of now the diet, the exercise, you can move back to the green. And that's where usually we can do that. And at times even just add a single tablet, what we call the metformin, just to improve insulin sensitivity. But remember, when now we reach the point that you already have diabetes, we know that the effects of the sugar in the body have already started bringing complications. So I'm not looking at you as today, Duncan, that we are sitting your diagnosis for today. I look at you in another 2 to 3 years. What kind of life do I want for you? So usually it means that I want a life for you that is complication free. And how else will I be able to aggressively lower your sugars? Because remember, diet and exercise is not easy. Yes, I've done diets, myself from time to time. I do exercise, but at times, we are busy. We are here now. This would be exercise time,
Yeah.
but we are here. So you see, life is busy. We are chasing the coin. There is life issues. Everything is pulling us, so you might not be able to really do your exercise as it should be. Diet, we are approaching the festive season. No matter how disciplined you are, temptations will be everywhere. So you see, if that's what we are only relying on to control your sugars, we will definitely fail. But you don't ignore it. So usually you start the medication as you still continue reinforcing diet, exercise. That's how come every time, even our patients we've managed for years, I always remind them. At times they'll come, their sugars are a bit off. Before you quickly adjust the medication, you discuss diet. Then they'll tell you that honestly, doc, it's been crazy this couple of weeks. I know I've done this. And that's why we always again still send them back to the nutritionist. So the earlier you lower your blood sugar, the better. And even if HbA1c just drops by 1%, your risk of complications, what we call microvascular complications, those are the eye complications, the kidney complications, the nerve complications, reduced by almost 30%. So imagine by aggressively just lowering for you, let's say a HbA1c that was 10 to 9, you're already preventing complications. And these are long-term complications. That means like 5, 10 years from now. So imagine if I drop your HbA1c from like 10 to the target of 7, it means that in the next 10, 15 years, if we stick by it,
Yes.
then our outcomes would be better.
So do I hear you say that HbA1c is one of those really good measures that you can, or yardstick, you can use to kind of, get a sense of whether you're doing well and avoid complications. And if your HbA1c then is, let me say, not to the required standards, what kind of complications are you able, to expect? And of course, and lastly, before I check, some of our members whether they've got questions. So let me repeat myself to be a bit clear. So yes, HbA1c is that yardstick, and I like how you've explained, it's, to avoid all these complications, there's a certain level of, let me say, measurement, or rather, HbA1c of 6 or 7, whatever it is. So when and where do you want it so that someone doesn't have complications? That is one. Two, what kind of complications are people with diabetes likely to see? And three, and I'll
Akisi, I'll
repeat
forget.
myself. No, no, don't, Usijali. Okay, let's answer those two
Yes, let's answer
first.
those two
Yes.
first. So first, the reason why we love HbA1c is because that one you can't cheat me.
Okay.
Yes.
Oh yeah.
Oh, yes.
Mhm.
Especially, when we treat the teenagers, they are very naughty.
The ones who come with the wameandika anaandika akikuja clinic.
Eh,
My sugars were 9, 8.
yes. In
Okay.
fact, at times that's why we even like when we work with the educators,
Yeah.
other than the diary, because the diary, at times some patients will write good
Of
numbers.
course.
Then when they see one reading that is a bit off, that one they don't record. Yes. Or some the sugars are high, they'll tell you, doc, I didn't do, I ran out of strips. Or some actually, especially the teenagers, when they're just about to come for clinic, they inject, they eat right, they give you a very good chart. Yes. So that's where HbA1c catches
see.
them.
Okay.
Yes, because HbA1c looks back
Mm.
3 months.
Mm.
Yes. So it's able to tell you what your chronic sugar, what we say long-term sugar for the last 3 months has been. And also when we set targets, every patient is different. Yes. So someone young, you want to be very aggressive. And the reason you want to be very aggressive is they still have their lives ahead of them. And you look at their lifespan and longevity expectations. So if you're like 18, I expect you to live till you're like 70
80
or 80, 90. Yes.
Yes.
They're actually the longest person with type 1 diabetes lived up to, I think it was like 99. Yeah. So we want you to live long. So for you young patients, we set very aggressive targets and usually 6.5 to 7% of the HbA1c.
6.5 to
7%.
7%.
Yes. As long as you can reach it safely without getting your hypoglycemia. But if you're elderly, you already have complications, you have heart disease, you have kidney disease, your leg is amputated, your eyes are not seeing very well, or even you're just diabetic and you're at 80, surely. We know even with God's graces,
Yeah.
you've already made it that far.
True.
There's no need to be very aggressive. So those ones you are a bit relaxed, even if their HbA1c is between 7, 8, 9, you're not too harsh on them. So you relax depending on patient factors. Yeah, so that's how we determine sort of the targets.
Okay, but it is individualized.
It is individualized. In fact, everything about diabetes is individualized.
All right.
Yes.
So I need to check our groups. Thank, thank you so much, Dr. Harry. Just to, I hope we are live. I think we are. So just trying to go through some of the questions. We have a retreat tomorrow at Karura grounds. So one of the members was wondering whether Dr. Harry will come tomorrow.
I hope it doesn't rain for starters.
Okay, unasema muulize kama anakuja kesho hangout.
Kama nitakuja.
So
I will really purpose to attend.
yes.
Yeah, but we'll see.
All right.
Yes.
Let's see. One person here says that there's an issue with the lower back pain. I'm sorry, I haven't read through this question, so vile unaisikia na mimi ndio naisoma. So I've been experiencing lower back pain lately. Went to hospital and at least did the major tests: kidney function, lipid profile, HbA1c was 6.0, vitamin D3 and B, and all were along the normal ranges. I'm on glucophage 1000 times 2 and Damicron 30 mg times 2 daily. What would probably be the cause of this pain? Yet I've not fallen or carried anything heavy lately. It's a tough one, I don't know, but that's your question. I mean, some of those questions, as I said, I haven't read through them, so it could be some would require, we in personalized, or individualized, contact. But what's your take?
First, let's applaud him. His HbA1c looks good.
Yes.
Yes. And with that, we already know that his sugar is not the problem. Yes. So at times, back pain can come for so many reasons. We don't know his age. We don't know what he does.
Okay.
These days, even people work from home, their posture is not really the best. So you might just find it's things like either muscular, just the muscles are a bit tight. Or if the age is also a little advanced, you might find these age-related changes, what we call degenerative disease. So usually it would really need to be looked at. Simple, at times you just start with an X-ray. If we don't see anything on X-ray, then at times we'd recommend MRI. If MRI is fine, usually just physiotherapy. Physiotherapy would sort of do it. But diabetes doesn't really affect the back, so he doesn't need to worry.
Okay.
Yeah.
All right. So we'll get in touch with him. So there's another comment here from YouTube. Jane Jogu asks, what could be the problem with a kid with diabetes? Starts scratching and she says it's itchy.
So what happens at times if you've had diabetes for so long, whether it's and children or those with type 1, we start seeing complications when they've had the diabetes for at least 5 years. Type 2, at diagnosis, majority usually have complications here and there. So at times what happens, they get what is called autonomic dysfunction, and at times the skin is really dry. We tend to see it a lot in the feet and the legs. So that's how come you find some of our diabetic patients, their legs just always look scaly, ashy. So, that sort of dryness is what makes the skin really itchy. Then at times now they would scratch, then you get small bruising, then the bruising leads to a wound, then the wound leads to sort of other things.
Okay.
Yeah, or it could just be this just normal scratching, nothing to really, really
Nothing.
worry about.
All right.
Yeah.
Very nice. So let's go back to our conversation to just talk about one or two things. So, of course, what tests would you advise people with diabetes to, kind of um, do maybe annually, if I could put it that way, so that you can cover, at what point should I maybe have, this part checked or whatever, annually? What type of tests?
So first, maybe we would move a step back.
Yes.
I know we left the story of complications hanging.
Yes. Oh, yes, yes, yes.
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 So that also usually determines what tests
Okay.
we can do. So remember, the complications of diabetes can affect literally every part of your body. Some people are unfortunate to have many multiple complications. Some people it's just one here. There. Some people are lucky and have none. But we always purpose that either our patients do not get complications, or even if they get it, it's much, much later in life, or even if you find them, they are sort of slowed down so that the progression is not very rapid. So complications can literally be anywhere from head to toe.
Okay.
Yes, but usually we classify them as either small vessel disease, what we call microvascular complications, or large vessel disease, what we call macrovascular complications. So small vessels are here mainly the eyes, and the eyes is anything from cataracts. Cataracts are just the whiteness you see in the eyes. We see it a lot in the elderly, but the difference is with diabetes, you get premature cataracts. So you see someone who is 20, 30 having cataracts. They get things like glaucoma, which is just hypertension of the eyes, or now they get what we call retinopathy, which is bleeding on the back of the eye. That's the retina. Yes, so different changes there until ultimately now there's vision loss, which is blindness. It is scary, yes. And it's usually it's premature, it's early. Then you can imagine now if you didn't have your eyes.
Yeah,
You wouldn't work. Your life just changes, that adaptation. So there is that. Then now when we come to areas like the mouth, they get recurrent dental infections. Some people even lose teeth, what we call gingivitis, inflammation, bleeding of the gums. Then then now the other areas we worry with those small microvascular complications are the kidneys. But remember, kidneys don't give pain. Most of my patients, panic. Like now the one who wrote their back pain,
Yeah.
they think it's their kidneys. No, kidneys don't give pain. Yeah, so kidney disease. And if you walk into any dialysis center, majority of those patients usually have diabetes. Yes, so you know the cost of dialysis.
It's very expensive.
Yes, NHIF would barely pay for you. They just cover 2 sessions and you need like 3 sessions a week. Yes, so kidney issues. Then, of course, nerve issues where we see erectile dysfunction, and then now the feet. Yes. So remember, the reason you have nerve supply is so that if even you stepped on something, you should be able to feel it and you remove your leg. But our patients
Sort of
with
a reflex.
diabetes, yes, do not feel. So they can just step. I had one patient one time, the way now it's cold.
Yeah.
You wash a jiko. Then they just sat there warming themselves. And imagine the feet literally got burnt with blisters because they can't feel it. Yes. So then that's where you get like sort of those wounds that also again lead to at times the amputations. Then now when you look at big vessel complications, those ones usually are very dramatic, either a stroke or someone heart issues, which can either give you heart attack, heart failure, or if they affect the blood vessels of the leg, then again, you find yourself with wounds that don't heal. Then some of also the other complications that we forget are now mental issues. Yes. You can imagine you're a teenager. Yes, you have to inject this many shots. So we see a lot of depression, actually, anxiety, depression, in some of our patients with diabetes. So usually once you go through some of those complications, once you know that, that's when now again you find you tailor your treatment sort of to
Towards
that.
the person.
Yes.
But just in case someone missed it, how can one avoid these complications?
So how you can avoid these complications? One, accept the diagnosis. At times some patients are in denial. Then you find they start going to some of these alternative things, alternative options, herbal prayers. You know, you see WhatsApp things you're told, oh, if you just drink ginger, you drink, if you what, your sugars will normalize. These are things doctors don't tell you about. No. So first is just accepting the diagnosis. At times some of these diagnoses are hard, but once you accept it, then you're ready for the next step. And the next step involves taking your medication correctly. Yes. Don't look at it. Ah, I know so and so also has diabetes. Them they are taking glucophage. Why am I taking this one? Why am I? No. By the time your doctor picks your regimen, it's sort of been tailored for you. So take your medication at the right time and at the recommended dose. We know some of this medication can have side effects. So usually if the side effects come, you'd rather discuss with your doctor without stopping some of
Yeah,
them
by yourself.
by
Yeah.
yourself.
Yes.
And then the most important thing is coming for those clinic reviews, because that's where now we decide how often you do your tests. Ideally, the HbA1c, like we alluded to, is best done every 3 months. But at times we also know cost is an issue. So if you have good control, your doctor can stagger that for you. So you might find you can do it even twice a year. Those that at times you're strict every 3 months is if you don't have very good control in between. And so you want to be sure you're sort of on track. So we check that as well. And then now the other tests, your kidney function, your cholesterol, we'll always check things like your thyroid, we'll do a urinalysis test, a heart test, which can either be ECG or what we call the echo. Those ones again depend. So if you already have a risk factor for one of them, then they can be done every 3 months or every 6 months. But if you're that good that your control is perfect, it can be done once a year. Yes. And then, of course, an annual um, eye exam. Yes, which I know is something we've been discussing to
Yes.
see how our patients here can benefit or how we can organize it for them. But an annual exam is always good once every year. So it really, it really depends.
Right.
Mm.
Really good. And I mean, I can tell you, and because I am, let me say, a lot of our members are open, some they're free, open, and to me, I get members honestly who confess that they stopped taking medication.